So I'm a board certified orthopedic surgeon. I have some advanced training in minimally invasive surgery of the knee, hip, and shoulder. And really my practice goal is to customize the treatment plan for my patients to really focus on what their individual situation is to get them to reach the maximum outcome that they can. And so knee arthritis specifically is really a serious public health concern as there's a lot of pain and disability that people experience when they're dealing with knee arthritis issues. There's a lot of time that's having to be taken off of work, and then quality of life issues with having to change daily activities and hobbies as a result of the knee arthritis, which is what leads to surgery. And that surgery in the United States on knee replacements alone is expected to double over the next 10 years to over 1.2 million knee replacement surgeries just in the United States alone. So it's a really big issue, and we want to make sure that we kind of understand it and do it appropriately. The knee arthritis usually presents with pain, swelling, and stiffness, and then as the disease progresses, mechanical symptoms of clicking and catching and then giving way of the knee is a big one. And then as it progresses further, knee deformities can form. So a bow-legged or a knock knee deformity and progressive stiffness. But knee arthritis really means inflammation, and that's what arthritis is, but that leads to cartilage damage, and then more cartilage damage leads to more inflammation. So it really is a cycle, and that's what leads to some of the bone spurring, the deformity, and when you have defects in the cartilage, that is the bone-to-bone arthritis. So that's kind of the end stage. And as the cycle progresses, we try to block that cycle with different things, and that's part of the treatment. But not all knee arthritis is the same, and so that's the important part. The first important part to understand is there's osteoarthritis. That's the normal wear and tear arthritis that can form. Rheumatoid arthritis is a little different, where it's an immune-mediated arthritis, and that really has a different picture and has different treatment options. And then there's a post-traumatic arthritis that's more from an injury that leads to the cartilage damage, and then that starts down the cycle. And then which part of the knee is involved? Because there's three main parts to the knee. We talk about the medial, the lateral side, and then the kneecap joint or the patellofemoral joint. And so if you have just one part of that knee involved versus the whole knee involved, that really guides the treatment options as well. The treatment options initially are aimed at reducing the symptoms. So if the knee's inflamed or swollen, anti-inflammatories and compression may help. If the knee's unstable, so later on in the disease giving way, that's when a brace may help. An initial period of rest followed by low impact exercises can help keep the knee moving, keep the knee lubricated, avoiding impact. And then injections may help with some of the inflammation to help lubricate the knee as well. Using a cane or some other assistive device to help minimize the impact on the knee may help as well. And then weight loss is another initial treatment option that may help with the pain. But as we get to surgery considerations, if those initial treatments fail, this is where it's really important to understand that every person's different. So some people just want less pain during their day-to-day activities, so being able to walk and get around with less pain. But some people have high demand on their knee. So some people are returning to a high level of competitive sports, like this gentleman, and some people put a lot of demand on their knee, so lots of heavy lifting and squatting. And those things have to be taken into consideration when we're planning how we're going to treat the knee. So the three main decisions first are which part of the knee would be replaced, if it's a partial knee replacement versus a total knee replacement. Then the next part is the technique, how we're going to replace the knee. And this is where the main customization options come in, whether it's the conventional technique of knee replacement, robotic assistance, a 3D printed knee replacement that's patient specific, and then the setting of the knee replacement. So inpatient versus outpatient or surgery center knee replacement options. So we'll go through those. Firstly, all the knee replacements really are just removing the damaged cartilage and bone. And so that's replaced with a metal and a plastic piece. And I think a better way to think of it is really resurfacing the end of the the end of the femur, the top of the tibia, so resurfacing the knee. And this graphic kind of shows just how little bone and cartilage is removed and replaced with the metal. And so it's a really resurfacing. But then the other really important part that's often overlooked is realigning of the knee. So if a knee gets out of alignment, which may be the problem from the beginning that led to the arthritis, that alignment needs to be restored to as close to neutral as possible. And that's what leads to the first decision of which kind of knee replacement to do. So the partial knee versus a total knee. If you have just an isolated part of the knee that's damaged, so just the one portion that has cartilage damage or cartilage loss, then a partial knee replacement's a good option. Typically has faster recovery because it's less invasive, and it's more reliably done as an outpatient surgery because it's less invasive. It typically feels more natural, so patients feel like this is more natural knee because a good portion of the knee is still their natural knee. The other part of the knee, the ligaments, are all maintained in the knee, so it usually feels more natural. But because there is another portion of the knee that's still the native knee, it could progress in arthritis. So there's a chance that the rest of the knee becomes arthritic down the road, which is one of the potential downsides of a partial knee replacement. Versus a total knee replacement, if you have multiple areas of the knee that are damaged, so the whole knee's involved, or at least 2 of the 3 compartments, then the total knee is a better option. The total knee is good at whole knee pain relief, and you can correct a lot of deformity and a lot of instability when you replace the whole knee. But it may feel more mechanical because it is more metal and plastic, so a lot of patients feel that it's a little more mechanical feeling, but then there's no more part of the knee that can become arthritic down the road. So it's more of the definitive treatment for a whole knee that's arthritic. And here's an example of a partial versus a total. So the very first x-ray on the left of the screen has the isolated medial joint that's bone-to-bone arthritis, and then the subsequent medial partial knee replacement, versus the picture on the right shows the global knee arthritis with bone-to-bone changes in both compartments of the knee and what a total knee replacement would look like in that setting. That leads to the next decision. What technique are we going to use? If we've decided on the partial or the total, are we going to use the conventional instruments? And typically the knee replacement, with some variation in instruments over the years, we have some new instruments that help, but this is the way the knee replacement's been done for years and years and years, is using some special tools in the surgeon's hands to help align the cuts, to resurface the knee, and to try to replace it as realigned as possible using the instruments. And this works very well, and we have high success with just the conventional technique. But this has led to the newer techniques, which are robotic-assisted knee replacement. So this is really using a robotic arm and using some computer navigation to help align the cuts just as accurately as possible. And the other part of the replacement, which is the balancing of the soft tissues around the knee, that is what I think gives us the most benefit to using a robotic-assisted instrument, is we can evaluate the knee intraoperatively and assess the tightness of all the ligaments, the range of motion of the knee, and then help change and modify the cuts based on that. A lot of the robotic equipment is based on a CT scan. So some require a CT scan to get more information about the knee, but some of the robotic instruments don't. And so the ROSA robotic instrument is the one I use the most because it doesn't require a CT scan. So I like that that's a little less radiation for the patient, and often the surgery can be done sooner without having to wait on the CT scan results. And it uses all intraoperative evaluation to help create a 3D model of the knee. And so that's just one less step, but it helps with aligning the knee as anatomically as possible. The other technique is using a patient-specific knee replacement. And so a CT scan is taken, and that's used to create a custom cutting jig and an actual custom 3D printed knee replacement. And this is an example of this, that Conformis is the only company that does that. And that is really nice in some patients' knees that have certain anatomy. And you can tell the knee replacement fits just perfectly because it literally was created for their own knee. So that's as custom as it gets. as far as that goes. But that requires a CT scan and some lead time to create the knee replacement. Then the decision of where the knee replacement will be done. And so inpatient at the hospital versus outpatient. The inpatient typically stays 1 to 3 days in the hospital. Outpatient means they go home the same day. And the outpatient can be done at the hospital or actually at a surgery center. And we're doing more and more of these on an outpatient basis for various reasons. Patients who are qualified for this, they have an overall health status that's good, minimal medical problems. They have to be motivated to be able to do the physical therapy and put in the effort to do it and to go home the same day. And then really need good support at home. So family or friends that can help them within the first week or two of surgery. It has a lower infection rate in general. There's lower surgical site infection rate and then other hospital-acquired infections from actually being in the hospital and exposed to the germs that are in the hospital. That's why we push for more and more outpatient surgeries. Typically lower complication rates associated with that. And then usually a quicker recovery. So patients who have outpatient surgery are typically recovering quicker. So we're pushing more and more patients who qualify for an outpatient surgery to be done on an outpatient basis. And so in general, the knee arthritis treatment needs to be customized. And so that's the most important thing I would encourage you is to talk to your surgeon about the 3 knee replacement decisions, which is the type of knee replacement. Is it going to be a partial or a total? And that should be customized to your location of arthritis and the type of arthritis you have. The technique that's used for the knee replacement, so whether it's the conventional, the robotic, or the 3D patient-specific knee replacement options, they all have their pros and cons, and so those need to be discussed with the surgeon and evaluated for your specific type of knee replacement goals. And then the location of the surgery, whether it's going to be an inpatient, outpatient surgery center. And again, all those have their pros and cons, so you have to evaluate those based on your individual setting. So now we'll transition to the benchmarks. Thank you for your attention during that presentation. That's kind of an overview of those knee replacement options. And I'm happy to take some of the questions now if we have any questions, and there's more information available on the website there. So let's see if we can see some of the questions if we have any.
Dr. Dabbs, do you see towards the bottom, the chat function, there's a couple of questions that have come through. Here we go. Is there a measurable difference in infection rates post-op with a partial replacement versus a total knee?
Yeah, so that's a good question. For the most part, that infection rate is very similar. So the invasiveness of the procedure, so the longer the surgery takes, the bigger the incision, usually leads to more infection rate. So if a partial replacement has a smaller incision, quicker surgery time, less invasive, and can be done on outpatient basis, then those things will have a lower infection rate. Then another question similar to that is, how do you control pain? So that's the biggest, I think, improvement that we've done over the last 5 or 10 years is the pain control after a surgery like a knee replacement. We have a multitude of modalities to help with that. Initially, there's a nerve block that's done by anesthesia at the time of surgery, and that usually gives a good 12 to 24 hours of pain relief from a good portion of the pain. And that's been the biggest benefit to allow people to go home the same day, is they're not requiring IV pain medication after surgery. The block helps with that initial pain. And then there's a variety of other medicines, anti-inflammatories, nerve medications, muscle relaxant, and then some low-dose pain medication, narcotics. All of those are recommended for the first 24, 48 hours after surgery, and then begin taking it as needed. So the pain is controlled usually really well with that list of different pain medications, anti-inflammatories, nerve medicines after surgery, so that outpatient is doable.
Dr. Dabbs, we have a member, an attendee here who would like to ask a question. I'm trying to unmute her. Kathy? Kathy, are you ready to
Yes.
ask your question? Go ahead.
Yes, I would like to know what the failure rate is of the CAD custom replacement.
Yeah, so, it's been similar to a conventional total knee replacement. And so when we talk about failure rates, we look at the knee replacement usually at, say, certain time points after surgery. And when we look at a 5-year to a 10-year failure rate, we look at a few percentage of knees fail for various reasons. You have a small percentage that have infection. You have a small percentage that have ongoing pain, and a small percentage that may have loosening of the implant for various reasons that may have to do with the cement or the technique that the implant was put in. But the custom printed knee replacement has similar. Some studies look like it's a little bit better, though it's not been out for long enough to look at a 20-year survival rate, but in the 5 to 10-year rate, it's similar, if not a little bit better than, say, the conventional knee replacement. Now, there are studies that say the custom knee replacement feels better. Patients may be a little more satisfied with the knee because it feels a little more natural to them as it's made more natural for their knee. But the failure rate of it is similar.
If it fails, then you have to go in and do a revision?
That's right. So if it fails, and it depends on what the failure means, but yes, if the implant fails, it comes out of the bone, or you have an infection, then you have to go in and do a revision, which is changing out the parts, taking care of the part that's loose or damaged, and putting a new part in.
So is the incision in the front or on the side?
Yeah,
How do you put in the CAD?
Yeah, the incision part is another decision that's technique based, and it can be on the side, it can be on the front, but really the patient specific, that CAD that you're saying knee replacement is what we call the least invasive, because we don't have to put any extra pins in the bone, and we know it's custom to the knee. So it's the least invasive option as far as the trauma to the knee. The incision, though, is about the same, and it's usually just on the front medial side of the knee to be able to get in and do that. There are some surgeons, for various reasons, may have to do the incision more on the side of the knee based on your deformity. But if you have a normal knee arthritis with a normal bit of a bow leg deformity, that's the most common, then the incision will be on the front to the inside of the knee.
What is the blood loss?
So the knee replacement's nice because we can use a tourniquet and you have small blood loss. Normally it's around 50 cc's of blood.
Okay, and I don't really know what that is. 1/4 of a cup, 2 tablespoons, 1/4 of a cup.
Yep, something like that. So not very much for the knee replacement. That's the nice part, is we can use a tourniquet. There's also some other medications that we use that help decrease blood loss now, that we give at the time of surgery, that decreases the risk of having to do that. Almost never is a knee replacement a surgery where you have a lot of blood loss, where you're needing to have a transfusion, because we can use a tourniquet. So that makes a big difference in that.
Okay, thank you.
Hey, you're welcome. Thanks for the questions.
And if you guys will just continue, you can either raise your hand like Miss Kathy did if you want to verbally ask your question, or you can put it into the chat box on the side.
I see another couple questions there I'll address. One is the typical recovery time. So this is a part where I say everybody's different for sure too, and different in terms of what their goal is for recovery, what their job is, what they're trying to get back to, what type of arthritis they have, how old they are. All those things matter as far as recovery time. But usually within the first 6 weeks, most people have done really well to where they are ready to go back to work in some capacity. Therapy is usually done around 6 weeks as far as formal therapy, and then self-directed therapy going forward may be done for a few more weeks after that. But I'd say the majority of the recovery is in the first 6 weeks, where depending on how strenuous your job is or your daily activities are, you're getting close to ready to return. Some people, again, are much sooner than that. Some people are later than that. The partial knee replacement's usually a little quicker, so more like the 4-week range, and the total knee is more in that 6-week range. And then again, depending on a lot of other factors, that's patient specific. Let's see. So another question is about infection risk. Is yes, if you have an autoimmune disease, and it depends on what that is, but you may have a higher infection rate. So depending on what kind of immune medications you're on, how well controlled the disease is, you may have a slightly higher infection risk. So some of that we have to take into consideration when we're doing the surgery, determining what kind of medications we're going to put you on, if you need a prolonged antibiotic course after surgery and to keep a closer eye on things, or if we put antibiotics into the knee itself. Those are all considerations if you have an autoimmune disease or a history of infection that may make your infection risk a little higher.
Dr. Dabbs, did you see the question about methods to avoid incision into the quad muscles?
No, that question not coming up, but I can address that some. So the majority of the incisions that are made, whether it's on the front of the knee or the side of the knee, the quad muscle and the quad tendon is spared. And so we don't cut across the tendon. If any portion of the tendon or the muscle has to be incised just for exposure of the knee, then all the studies about that have shown that the recovery is very, very similar. So making an incision on the side of the knee to try to totally avoid the quad, the time point outcomes are so minimally different that it's rarely worth the risk of doing that kind of incision to try to save the quad. And what I mean by that is the exposure to do the knee replacement is important to be able to see what you're doing in the knee, whether you're using the robotic arm, the custom, or a partial knee, all that. The exposure to put it in exactly perfectly is important enough that if you have a difficult exposure because you're trying to protect every bit of the quad and the implant ends up being a little bit crooked in there, then the outcome won't be as good. And the benefit of some speed up recovery, maybe just a few days here and there, and in most of the studies about that, it really is just a few days of a benefit as far as quad function and range of motion. So usually trying to protect the quad at the risk of poor exposure is not worth it. So we always, as far as myself goes, avoids cutting the quad as much as possible, and rarely ever is that involved in the incision. So it's always next to the quad, but if we have to release a small portion, we repair it, and then the outcome is essentially the same in all the studies about recovery by that 6-week time and the 3-month time, and even the 2-week post-op. It's within a few days as far as the strength and range of motion. So that's most of the studies on that, I think, is important enough that the exposure is more important than trying to totally respect the quadricep mechanism and struggling with the exposure.
Dr. Dabbs, one of your participants, Jean, has a question. So I've unmuted her to let her ask that.
Hi, Dr. Dabbs. Maybe I'm past all this because I think I'm one of those outliers that I had a knee replacement last year, total left knee, and then I didn't do that well. Went in January. Turns out I had a whole bunch of scar tissue removed, had, the big incision again the second time. Mm-hmm. I've got all the range of motion and everything, but my pain is and my limited activity is the same as it was, which made me decide to have the knee replacement. So my next step now is I'm going to do a nerve ablation, but I just wonder, is there anything left for me? So that, because I was expecting, you know, to just bounce back to my normal self. So
Yeah.
what's left for people like me
Yeah. So
if the ablation doesn't work?
yeah, that's a good question. And I think that's a part of the knee replacement where if you have bad arthritis as the only source of your pain, then the knee replacement takes care of all the arthritic pain. If there's other pain that's either nerve pain, tendon pain, bone pain that's around the knee, then that pain may not all get better. And so I think that nerve ablation is a reasonable thing to consider. But that's why it's so important for the alignment of the knee. So not only the front to back and side to side alignment, but the rotation of the knee replacement, that it's as perfect as possible. And that's why the robotic and the navigation and the custom knee is important, because some of that rotation, even with all the instruments and things being as good as they can be, the way we've done it for years and years, there's a small bit of outliers as far as the rotation and the alignment of the knee that it's harder to appreciate with the normal instruments. And so using the robotic to guide the alignment and the rotation helps reduce the number of people like you that have had more trouble if it's something about the rotation or the alignment of the knee that's continuing to cause your pain. So I think if the
Is there a way to
ablation,
find that out?
yeah, so there's some other things to do for working that up. Some CT scans at this point, say after a year or so, you can get a CT scan and we can measure the rotation better of the knee replacement with the CT scan. And somebody who's had pain and is not doing well, that's usually the next best thing to do to help measure the rotation of the knee. Because if your knee is rotated off a few degrees, you may still have problems that the implant itself looks good and it's well fixed, and that's not an issue, but the rotation or the alignment of the knee may be a problem. So you can talk to your surgeon or a surgeon about that and see if a CT scan for alignment issues might be something to consider, especially if the nerve ablation doesn't help. If it's not just nerve pain, it could be something about the alignment of the knee that could be addressed.
So there's a possibility that if the ablation, there's still hope for my pain to go away, in other words.
Yeah. And I don't know exactly what your situation is as far as the knee goes, but yes, usually your workup of your pain isn't done until you've had some more tests. So some more, the CT scan, and there's another bone scan that may be worth, once you get out here, now that you're a year out, those things would be reasonable to consider to continue to try to figure out your pain. I wouldn't give up hope yet.
Oh, please, no, I don't want to.
Yeah.
I got a lot of life to live still.
Yes. Yeah, of course.
Thank you.
You're welcome.
There's a question down here about discussing the relationship between the knee and back pain.
Yeah, so I think they're all related. You're right. So whatever the question is, there is the relationship, because the mechanics from your ankle to your knee to your hip to your back are all related. When you have one of those joints that's not working right, that's either not aligned appropriately or that has damage, the joints that are next to it then see abnormal forces and start to hurt. They don't function the same way. And so, yes, addressing one of those joints, and you should have them all evaluated. So whoever's taking care of, the knee and the back, they definitely work together as far as the function, your mechanics, how you move. And a lot of that can be addressed with physical therapy to help with your biomechanics. But if you have a joint that's just really arthritic, that's not functioning right, then taking care of that malfunctioning joint may help with the other joint. So if the knee's arthritic or gets out of alignment and the replacement restores the alignment and motion, that may help with the back pain, if then you can get back to a more normal biomechanics of how you get around and move. So they're definitely related, more so the adjacent joints. So you say a hip and the back, as they're closer to each other, the hip and the knee and the ankle are more closely related, but the whole mechanics of the lower leg to the back are important to assess. And that's why some of the robotic part helps with that, because it really does help align the hip, knee, and ankle as accurately as we can possibly do it, which helps with the rest of the body mechanics.
Okay, we have a question up towards the top, and I'm not sure if this was addressed. This is from Jill. Jill has 2 torn meniscus and has been getting shots every 3 months. I've had these shots for a few years. Does this hurt me?
The shots, do the shots hurt? Is that what that sounded like, getting shots?
Yes.
Yes. So if you're getting shots in the knee, if you have a knee that's painful and inflamed and a shot helps, then, and you're not getting a bad reaction to the shot, so having a bad flare of pain after the shot, having diabetes where the cortisone in your knee and your body is causing a spike in your blood sugar, then getting shots on a basis once or twice a year for a long, long time has not been shown to cause any problems, especially into a joint. If you're having shots into other spots, like into a tendon area or into your soft tissues, then there's more of a risk of having some localized problems with steroid into the tendon or the tissue. But into the joint, for a joint like that, spreading the shots out every few months is okay. So that I would continue to do that, but talk to your doctor about the other side effects. If you're having any problems with those shots, like I said, like a flare or blood sugar problems, otherwise it's reasonable to continue them if they're giving you relief from your pain and putting off some other treatment that you may need.
Debbie asked if you do all of the types of knee replacement procedures that you mentioned in this presentation.
Yes, yeah, and I think that's important, is I offer all of those depending on the patient's individual situation. So if they have a certain deformity or a certain goal that I think they would do better with one versus the other, then I'll give them those options. And so I do offer all of those based on each person's individual kind of situation, type of knee arthritis, location of arthritis, all those are my options. That's why I think if someone is treated the same way, if you get a certain knee replacement every time, that's the part that doesn't fit all, is you need to be able to offer various options, because each option has a pro and a con that has to be weighed to the individual situation. So yeah, I'll offer all of those.
Dr. Dabbs, can you, we have a attendee who has asked how long you've been practicing. Would you like to give a little history?
Yeah, so I've been here for over 6 years now in Knoxville practicing. And so I've came from Springfield, Illinois, where I did my orthopedic training, but I'm local, grew up in the Knoxville, Maryville area. So this is home, but I've been here for over 6 years now. So I've done thousands of joint replacements now over the last 6 years.
I'm not seeing, I think we've addressed most of the questions that have come through the chat. Wanted to let everybody know that what we're going to be doing is this presentation has been recorded. And so we will send you a link to the presentation via email, and that will be